take a moment to introduce myself. I know a good number of you throughout the department. Some people may not know me. I'm Andrew Johnson. I'm one of the fourth-year residents here, currently serving as co-chief with Andrea Conway. I started my career, grew up in Osceola, Wisconsin, just ever so slightly into Wisconsin, but very close to Minnesota. Came here for the undergrad, did biomedical engineering, then went to med school here, during which I did the post-sophomore fellowship. So I feel a number of faces feel that I'm very familiar and have been here far, far too long, because that was about 7 years ago that I started showing my face around here. So people may think I clearly should have graduated by now. But at that point in time, I also did start working with Steve Schmeckel on this prostate cancer research, which included, at that point in time, just physically taking glass slides and lining up quadrants to see if you could make a whole cookie to what it looks like, and taking just digital photographs on a table. So it's come, I'll say, quite a bit further than that at this point. So I'm going to go and talk, my talk is Prostate Cancer and the Search for Prognostic Biomarkers and Correlation with Imaging Studies. And just to start off with, I have nothing to disclose, as you could imagine. And objectives, we're going to talk a little bit just about prostate cancer and then describe the use of digital pathology and research and how we're utilizing it, and then take a look at our development of these prognostic biomarkers to be able to kind of correlate that with prostate cancer and correlation with imaging studies. So I know prostate cancer has been talked about a number of times in this forum, and I guess I'd like to say it's probably because it's a very common cancer that you get to hear about it again today. And so some estimates: in 2008, nearly 1 million cases and almost over 250,000 deaths worldwide. In the U.S., it's estimated that we'll have about 240,000 men who will be diagnosed with prostate cancer. So it is a significant cancer in that realm. Now, taking a look that it disproportionately affects older gentlemen, as you can imagine, and are well aware that, yes, it's going to be in older people, and that brings up the point of what kind of interventions should we do in this patient population that probably have other comorbidities and actions like that. So taking a look, I put here prostate cancer management mostly because treatment implies, I feel like some sort of action has to be taken. And with prostate cancer, one of the current debates, or one of the debates on the forefront, is kind of whether to intervene or not. We've got some different options. Radiation therapy, we've got external beam, the seed therapy with the brachytherapy, where they recommend you don't ride any city buses after you get those implanted or have your grandkids sit on your lap. Otherwise, we have radical prostatectomy, which has its own set of morbidity and mortality associated with it. Namely, a lot of times you can have issues with impotence and incontinence with that. And so it's not something that you necessarily want to take on lightly. Androgen deprivation affects where you can have increase in coronary artery disease, other mental concerns, increases in depression. And then we get down to the point where the debate comes, is whether we need to intervene at all, whether we should do some of these observation methods where we're doing either active surveillance, where you're doing some sort of intervention when you do progress, carefully monitoring PSA, doing rectal exams, or even intermittent biopsies to take a look. The other option is watch and wait completely, where you're basically waiting until the patient becomes symptomatic before you want to progress to some treatment options. And the goal here is just to be able to try to decide. We want to be able to treat the ones that are going to behave badly, be bad actors, be aggressive. We want to try to intervene in those patients, but the ones that are going to have a low-grade indolent disease and are going to die of something else well before their prostate cancer is going to become an issue, we would like to not have to intervene, cause all this morbidity in these patients. So the project that I'm a part of has a lot of different parts, and I am involved in a good number, but mostly the pathology component. And so there's components here with urology, the people recruiting the patients, radiology, performing our preoperative MRIs, pathology, where we're actually taking the prostate, sectioning it, digitizing the slides, and then analyzing those with annotations. And then the next area where it gets a little bit more fuzzy for me would be the computer programming component. There are a number of different software parts that are written. I didn't write specifically, and so I don't fully understand or claim to be a computer science professional, but another component of it. And then at the end, analyzing the data with biostatistics. So taking a look, our patients that we have that were recruited, and I, again, did not have a part in the recruitment of these because this is the endorectal coil, which is part of the prostate MRI. This is able to give us a nice clean shot of the prostate, so much so there's been a lot of advances with the MRIs such that you can even see extracapsular extension, and some of the patients are able to actually be, have kind of a staging MRI and have some, very clinical implications as far as treatment decisions based on the imaging findings. So taking a look, once you get it out, this is one group's approach because you have the imaging beforehand, and then in our study we're getting prostatectomy. We're going to section them completely and then digitize the entire prostate submitted. This group actually took their MRI data and then used a 3D printer to make these specialized prostate-specific molds. Now, for me, looking at prostates, I don't know that there's a whole lot of structural differences between, from prostate to prostate. Yeah, there are some variations, but, for the most part, it's kind of just variations on a theme. So I don't know, with the surgeon taking off some tissue extra here, that it really would fit as ideally as you'd think. But it does account for some of the issues that you're going to have, because prostates, as soon as you start sectioning, we have our imaging studies, which are, cut against a horizontal axis going against the prostate. And now we've taken out that prostate and you can turn it 360 degrees in every direction. Therefore, you may not have the same planes that you're analyzing with the imaging, comparing that to what you're looking at histologically. Their approach was to make this little egg slicer where you insert the prostate and are able to do a whole mount histological analysis of it. Our solution was a little less, I'll say expensive, because having a 3D printer to make a mold for each and every prostate that you have recruited is going to be an expensive task. This is a picture of the sectioning box that we have down in the gross room. Took some tools that we have available for us and modified them a little bit. So it's adjustable plexiglass. Each one of these slits here is the thickness that you want to submit in a cassette. So we're able to slice these, make a cookie of the prostate, and we modified this blade so that we can fit with those super sharp, super long blades in there and actually section the prostate right there. For a while we were even doing ex vivo imaging, because again the issue is you're imaging in vivo, you have an access for where the coil is then, but when you take it out you can still spin the prostate and it may not be perfectly parallel to the way it was imaged before. So we actually, for a while, we're putting the prostate in, taking it down to MRIing the plexiglass device, which is MRI. It's clear and you don't have to see it, so you can see right through and get your imaging of the prostate. So this is what it looks like, just the diagram we have of how we section it. So we get kind of the horizontal cookies of the prostate. Down at the apex, it's a maybe not exactly a cylinder, but you get the point, where then we section that perpendicular to the margin, so we're able to see still see the surgical pathology question of our margins positive or not. Then we digitize all of these slides, and this is where a fair amount of my efforts have been put in this exact room. We have a digital pathology, the Wacom pad with the pen that we're able to draw right on the screen and trace the areas of prostate cancer. This is what it looks like on the screen. Taking a look, we have where we're able to add different layers. So the first thing I'm doing is annotating out here the capsule to be able to show where the margins of the prostate are, because that's one of the things that they can see on imaging. We want to be able to correlate that. Then the next step was outlining the areas of prostate cancer. This one just had one large area of prostate cancer, ended up being grade 4+4. But out here on the edge, we're going to take a look there, and that's, excuse me, an area of extra prostatic extension there, which is also of interest to be able to see if we can correlate with what they can see radiographically and see that, the thought being that some of these more aggressive cancers are the ones that are going to start spreading, growing quickly, and expanding. So this is something that some of our colleagues presented at a radiology meeting, taking a look. So this is kind of roughly reapproximating those different quadrants of the prostate section, placing them back together. The Stitch software would kind of combine those capsules that were drawn, and this is using the transformation with reference to internal structures, because as soon as you start sectioning a prostate, there are a number of fibrous bands, and it's a compact structure when you first begin cutting it. As soon as you release some of those nodules, there's going to be deformation. It's not going to end up the same shape as what you were seeing on imaging radiographically. And so what some of the software does here is actually account for some of the internal structures. This nodule here is this nodule right there, and kind of correlates and allows for the transformation to be able to then correlate what we have histologically with the MRI findings, because it's not just a straight one-to-one visual, as you can see here, where it kind of has this bowing shape with the rectum and much more of a nice oval here. So next step is we want to take a look and see if we can kind of come up with, the goal is to come up with some prognostic biomarkers. And so to know that, we need to be able to see, can we come up with this signature at the protein level of what, how can we represent that? And so this gene expression profile, so a lot of times it started off, there's different methods about doing this. There's the kind of grind and bind assays where you basically take the tumor, mix it up, and then do your assays either molecularly or by other methods. But that kind of loses some of the information in the sense that there's specimen heterogeneity, there's vascular, fibrous tissue, benign stuff mixed into the tumor that you'd be analyzing, on top of the fact that even within the tumor there are different areas. It can vary from side to side as far as what its expression would be for the tumor. So immunohistochemistry has some advantages in the sense that you can actually do it on this microscopically interpretable section. So you're able to actually take a look at certain cells. So you can say, am I looking at carcinoma or am I looking at background? You can take a look at even subcellular areas. Is it nuclear staining? Is it cytoplasmic? Is it membranous? And you can get a lot of information on what's actually staining in these cells and on these sections. You can also do it, do a number of different proteins, sequential sections. You only have the thickness of whatever your microtome is going at between the sections, so even less than the diameter of a nucleus, you can get the information right next door. And again, with turnaround time, theoretically, these immunohistochemical stains can be into the workflow for the most part that have, we have prompt, same-day turnaround on some of our IHC slides. So taking a look, how do we kind of take that information and make it useful? If we're trying to do kind of a signature, you can kind of take a weighted sum of these gene expressions, and so either getting a positive or negative vote depending on what kind of outcome you're talking about. Is there cancer? Is there not? Is it an aggressive one? Is it not? Is it going to respond to therapy? Is it going to be resistance? And depending on what your outcome is that you're wondering, you kind of say if this gene is expressed, it gets a positive vote. If it's not, depending on that. So if it's upregulated, downregulated, depending on what our cancer is. And then obviously the degree of association, that magnitude, can vary with the expression of these these markers. So this is just kind of a generic expression of the voting classifier, taking a look where R is your spatial dimension, so the area that you're looking at, some sort of weighting factor like we were talking about, positive or negative, how intense it is, and then for each of those you kind of sum up and you get over the area or over these different margins what the gene expression or what kind of expression is, if it's an aggressive, it's not, depending on what outcome you're looking at. So in the paper I'm describing here, we took a look at we picked 4 genes that are kind of known to be related to prostate aggressiveness. Of note, we're not saying that this is the signature that says this is an aggressive prostate cancer or not. This is more just to demonstrate the fact that we can make these signature maps. Later on we'll talk about how we kind of pick and choose which ones we actually want to use or what comes up as the best signature overall. So we used Ki67, proliferation marker, neurospecific enolase, which is a marker of neuroendocrine differentiation, CD34 for vascular, and then ones where there's downregulation, so losing the prostate-specific acid phosphatase is a marker of aggressiveness. And so the other ones, when it's upregulated, kind of shows aggressiveness compared to downregulation with this other marker can indicate that it's kind of losing differentiation, becoming more aggressive. So some terms that I'll use a little bit here, our reference slide, which is just our H&E compared to our IHC ones, which are the immunohistochemicals. The score is when we're taking a look just at a single grid region, and the map is when we take it on a single immunohistochemical slide and kind of rate the intensity of staining over that slide. And when we start getting to the signatures, then we can take a look. The most important one is the signature map, which is kind of the goal here to kind of see with the expression of these N gene. In this case, it's 4 different genes that we're taking a look at. What does that signature look like as far as aggressive versus non-aggressive in this case? So the SIGMAP software takes, first of all, we start off with a Perio. We start digitizing the slides. Then we spend the time annotating, either positive, negative, outlining the cancer. Then we import our images into SIGMAP. It's able to define how big of a grid we're going to look at to analyze these, do some of the transformation to be able to take it, because again, these are digitized slides that are not quite on the exact same spot on the slide every single time. Again, begin analyzing with SIGMAP to be able to kind of generate these signature maps that we'll take a look at and be able to take a look at the signature map. So this is the program window where you pick which slide you want to import. So this is showing taking the H&E slide. We're going to use that, and you can pick what kind of analyzing you want to do, whether colorimetric or which type of algorithm we're going to be using, and select those to be able to go forward. And this is where we have to do kind of a coarse alignment, because as you can imagine with most slides, the histotech does not place the piece of tissue directly exactly in the same spot every time, nor is it scanned exactly the same by a Perio even. And so to be able to get it even close, sometimes there are quarter turns. I mean, everybody who's looked at immunohistochemical stains and has been trying to figure out, okay, where is this? And we have to flip the slide upside down. That's what we need to do to be able to get it close, because the computer will take care of the rest in the next step, but we at least need to get it into the ballpark so that it's not trying to line up a round corner with a square corner or something like that. So the next step is this turbo reg, which does the kind of the final fine tuning, so we get it close, at least within the quadrant. So this is just the H&E slide. This is the PSAP. This is the one for the neuron-specific enolase, just to show some examples. So this is our reference slide that we annotate and have. Here we just took out the colors and just made it monochromatic so we can kind of show what's going on. So we have, this is where it is, the angle that's going on, overlay B over on top of that, and you can see that it doesn't perfectly line up. So if you're going to start analyzing what you annotated on the H&E slide onto this, there'd be parts that just would not work. And so the turbo reg is able to actually take that angle and adjust for it, bring it into alignment with the H&E reference slide. Here's another example where it's a little bit tilted up, able to tilt it back down. So this is kind of the first steps of doing it, digitally annotating. This is kind of color-coded as well. So we have some different regions here, different areas of prostate cancer. As you can imagine, there are benign glands intervening between these different areas. This is showing where we have some 3+3 is outlined in green. We have some 3+4 out here in yellow, so kind of the intermediate. And then on this slide, the more aggressive one is this 4+3 area out here on the peripheral side. I'm going to use this slide to kind of show how our signature map works. So the next thing we do is overlay this grid, being able to say, okay, if it's, I think, greater than 50% is within one of these regions, then you're going to be able to use that square, and that's going to be something that we're going to analyze when we use the SIGMAP software to be able to take a look at the data on the immunohistochemical stains. So now we take this, the immunohistochemistry slides, overlay the portions that are generated from SIGMAP on there, and take a look at the intensity. So this was for the PSAP, where what's the intensity of the brown staining in those annotated areas. And just roughly, this is just to be able to kind of show what's going on here, but you can get the sense that, yeah, in the green areas, in the 3+3, the less aggressive areas, the lower Gleason grade, there is more intense staining by PSAP in those areas, especially comparing it out to the 4+4 region here. Take a look. So now this is going through all 4 of the genes. So we've got A, B, C, and D, which I had listed before, but for ease, we don't really need to care what genes they are. So these are ones A, B, and C, which would be ones that are positively associated or upregulated in a more aggressive cancer, compared to gene D would have been the PSAP, in which when you lose that expression, that's related to more of aggressive cancer. And do kind of a combined weight. So the weighting factor is positive in these, negative down in this one, and get a summation over the total areas of these different immunohistochemical slides onto a kind of signature map. So this is that last layer, that section E from the previous slide here, where again we have what kind of that heat map of all of these genes summated over the different areas. And so in our green 3+3 areas, it tends to be more primarily blue outline, so theoretically less aggressive, comparing that to some of the more aggressive 4+4 ended up being a little bit higher. So again, this is just to demonstrate that we can summate and do, utilize these different signature maps to be able to analyze what data we have coming in. So this is a little excerpt from a presentation I gave down at USCAP, taking a look at these prognostic biomarkers to be able to take a look at, okay, now we have the tools available, how, which signature should we use? Because we know those 4 kind of worked, but now we need to take a look and figure out what's the best one, what's going to show the most aggressive, the aggressiveness of prostate cancer. So we have got a number one. We kind of weeded it down to 33 genes based on kind of our own research, be able to take a look at different reviews, published reports, and like I said, our own work. So this first column here is 11 genes that we came up with based on our own cross-study analysis of 3 publicly available prostate cancer gene expression data sets. And the second column shows 4 genes that came up a lot in our literature research and have multiple occurrences published gene signatures on prostate aggressiveness. 6 genes here associated with hyaluronan metabolism, which we examined given the known association with hyaluronan signaling in prostate cancer. The next 4 were genes implicated in poor prognosis of prostate cancer. These next 6 are ones that are related to neuroendocrine differentiation, and we also included an angiogenesis marker as well as the tumor suppressor gene P53 were also studied. So taking a look, one of the endpoints that we're using to kind of term aggressiveness would be biochemical recurrence. It goes by a couple of different names, either PSA failure, biochemical failure. We are using the American Urologic Association's definition, which you have an initial serum PSA greater than or equal to 0.2 nanograms per mil, and a second confirmatory level of a PSA greater than 0.2 nanograms per mil. And so this paper actually took a look at how many different definitions there are of PSA failure out there, and there were close to 150 just in the urologic research. And then if you tack on the interventional radiologists with their definitions for doing external beam, there was probably another 150. So there were varying definitions. A lot of them are variations on a theme, but clearly it's a somewhat sometimes ambiguous term to just say PSA failure in these patients. So this is our kind of the clinical data and information of our characteristics of our group here, depending on the things. The things that I want to just kind of point out here are the fact that the significance there was association with aggressiveness or progression of or PSA failure with lymph node involvement, surgical margin involvement, and then it was correlated with age as well as far as being significant correlations. So taking a look here, we optimized our immunohistochemical stains on each of these biomarkers, and we used tissue microarrays to be able to take a look. And so we have 153 patients that we have PSA follow-up for that we utilized. And so the 153 patients that we have that PSA follow-up data for. So these are some examples of the hyaluronan synthesis. This is just 6 of the genes to just show as an example. So the immunohistochemical slides are the ones up top showing the brown. Then we used the Aperio pattern recognition software, Genie, and we're able to train it to be able to take a look at, and this is labeling the different areas. Either the glandular component is labeled dark blue, the stroma is labeled yellow, and then clear glass is that kind of lighter blue in there. So we're able to subset those different areas as far as what part we're looking at when we do the next analysis, because these different immunohistochemical stains have different targets. Some of the ones like the hyaluronan here is one that you're supposed to look at more in the stroma for positivity compared to other things. And then we're able to utilize that and take a look at what the intensity is of those staining in the different areas. And so the red indicates very high level staining, yellow kind of medium, and then the blue obviously is negative staining there. So you're actually able to quantify how much immunohistochemical staining we have in these different areas. So what we found, and I know there's a lot of words here, but focus on the big letters that you can actually read. So this is our hazard ratios, taking a look at each of these genes. And after adjustment, we have 6 that had significance, which includes the HMMR, HOXC6, IGF-1, MAP4K4, and SMAD4, were each individually associated with time to PSA failure. And so the things that we're adjusting for are how old these patients were when they got prostatectomy, if they had a sky-high PSA, the Gleason score, and if they had this non-localized tumor indicator, basically meaning they had either positive surgical margins or a positive node at the time of surgery. So in addition to looking at those genes each individually, we also took a look and tried to say, show, okay, how many different genes would be appropriate. So we took a look at kind of mixing and matching with 2, 3, 4, 5, 10, and 20 gene models to take a look at these. And the best one, the best area under the curve was for a 3-gene model using HMMR, SMAD4, and then the nuclear staining of SIH2. And that had the best performance in ours with an area under the curve of 0.721, and then the adjustment of 0.70, which had a p-value of 0.02 and a 0.02. So from this, some of the things that we'll be able to do with that information, we have all this information on immunohistochemistry, on tissue microarrays, and we found these 6 different genes that were kind of individually associated with PSA failure. And if we're taking our best number, whatever number of gene modeling, 3 of them using the HMMR, SIH2, and the SMAD4 had the best predictive value, or the best correlation as far as time to 5-year PSA failure. And it would, be able to further validate these studies. We'll need a larger data set. Estimate that we need at least 108 PSA failures to get optimal validation for these different studies, because obviously this is a smaller group with 153 patients. And we do have approval to be able to take a look at the prostate, lung, colorectal, and ovarian cancer screening trial group, and we are going to have access to their tissue microarrays, which has over 1,000 patients with very detailed PSA follow-up on all these patients to be able to further do more of a validation study. That'll help us continue to work with some of the correlation on the multiparametric MRI data. I want to talk a little bit more just about kind of one of the offshoots, some of the other things that interesting things, fun things that we've been able to do with some of the data, because we've been collecting so much as far as all the annotations on the prostates, all the MRI data, and there's a lot of stuff that we can do post, we have all the information, we can just analyze it in different ways. And one of the things that we were doing is taking a look at this colorimetric detection of prostate cancer. So whether we can actually have, kind of call out the areas of prostate cancer just by using digital imaging analysis. So what we did here in this one, and by the way, this was one that Ben Brasseur presented down at USCAP this past spring. So taking a look, again, hand annotated areas, the quadrant up here outside, so we want to exclude everything that's glass because we're going to be taking a look a little bit closer this time. Again, annotate the areas of prostate cancer. decide how big of a grid we want to have to be able to analyze how big of a section we want to take a look at, and areas that we have at least 75% overlap with specimen annotation, those are the ones we use. So we don't want to be analyzing, we already know that there's normal tissue mixed in amongst the prostate cancer already. We're trying to see if we can see the staining pattern around those areas. We don't want to be watering it down by only having half of it contained with cancer on top of the fact that it's already a percentage of normal tissue mixed in there as well. So we get this kind of smaller region that we're taking a look at to analyze that we've had annotated as carcinoma, and be able to take a look at what those imaging analysis is. So we take then our kind of a triple stain. So we've got high molecular weight set of keratin, P63, and then Racemase here. So we've got the two basal cocktail kind of stains going with the dab staining and the brown staining, and then the red staining here is the Racemase component. And so we're going to be able to take a look at what this ratio is to be able to say, can we call out cancer? So if there's a certain point at which, if it's the ratio of red to brown is, and it ends up being about 3 that we used, so 3 times as much red showing up in these areas compared to brown, well, that's probably prostate cancer. Racemase would be positive in the prostate cancer, and your basal cocktail theoretically should be negative in those areas. So this is kind of a heat map taking a look at the red colorimetric here. So the Racemase, as you already kind of got the vibe from on the upper diagram, more of the red staining here in the area that we annotated as prostate cancer. The brown staining, or the basal cocktail of the normal prostate glands, is less in the area that was annotated by prostate, or as prostate cancer, more out in the peripheral areas. Obviously there are some areas that are just purely stroma and have no staining for benign epithelium because they just have no glandular component at all. This is the blue colorimetric, taking a look just for the counter stain for the hematoxylin. Again, a little bit less as we have more of the red staining of the cancerous glands in here, a little bit higher in the other areas with benign epithelium. And then the other component, this is kind of backwards, but this is taking a look for the clear glass areas. So actually the glass is black and the tissue is white in this component, but we wanted to exclude areas and not be analyzing or taking a look at, or at least be able to say where is glass or where is empty tissue that we shouldn't be analyzing. So taking a look at where this ended up, and the cutoff ended up being at about 3.059, where our sensitivity equals our specificity for being able to say that the computer was calling, or where the ratio worked, that as you kind of dial it up, you can imagine that if the further up you go in the ratio as more red to brown, you would essentially get to a point where nothing would be called cancer. And as you dial it back down, if you get to a lower enough, then all of a sudden it would be calling everything cancer if there was even a hint of red available at all, anything. And so this is what it ends up calling out if we use the cutoff with a 85% sensitivity and specificity. And so we can see that it's highlighting primarily the area that we had annotated as prostate cancer. It's kind of focusing on those areas. There are some other areas that are popping up, and those would be things, this generally was area that was kind of more just stroma, so there's probably just a little bit of red that was staining there, but because it has very little benign epithelium, that red to brown ratio is such that a couple of these areas met criteria on this as being called as cancer. So it's not 100% by any stretch of the imagination, but it does seem to focus on the one area. So taking a look then, we did try to narrow down a little bit further, and we actually took 100 different sections, 100 different areas, and really focused on and did much smaller annotations in these 0.5 by 0.5 millimeter grids, and specifically annotating, you can see here on the end where we're outlining the actual benign epithelium, outlining the benign gland lumens, outlining the cancerous gland lumens. If there had been if it was at the edge of the tissue, we would say, benign glass outside the tissue, and giving these different areas to be able to take a look and see if we can correlate what's going on here. And so what we found is that there's kind of just marginal to good correlation between these colorimetric analysis and the fractional representation by cancer. So percent cancer, essentially the percent that was mostly red, had a fairly good correlation there, 0.749. So we were pretty good at saying whether it was cancer and agreeing on that, but agreeing on benign was a little less good, and lumen and glass was, again, not as good, and percent stroma, again, a little bit better, but not as great. So we're able to take a look, and it is able to kind of identify these different areas, calling out the things as carcinoma versus not, but it still obviously needs some improvement. So we only did 100 different squares because, as you can imagine, annotating each of those individual gland lumens in those areas takes a fair amount of time, and so to be able to really see if more association would kind of wash out as you got more and more data, would be a very time-consuming commitment to be able to figure that out. But based on that, we can kind of see that we are still able to kind of elucidate some of the characteristics underlying these multiparametric MRI findings, and we might be able to use some of these to better differentiate between the clinically significant and the indolent diseases, which is kind of the end goal. Taking a look at these biomarkers, though, we want to be able to predict the risk of disease aggressiveness after prostatectomy. And if we know which ones are going to be aggressive, which ones aren't, that would be helpful to be able to help these clinicians pick appropriate adjuvant therapies, to be able to approach, treat these people more aggressively earlier on if we knew which ones were going to behave poorly. And additionally, taking a look at these, as soon as we were able to further validate these prognostic biomarkers, hopefully use them as kind of gold standards in which we can train our other non-invasive imaging methods in these. And so as MRI becomes more and more advanced, hopefully that would be able to be a non-invasive way to be able to get information about prostate cancer. Again, started this work with Steve Schmeckel back when I was at PSF, and have been working with Greg Metzger over at the Center for Magnetic Resonance Research. And again, biostatistics, things that still boggle my mind with Joe and Rachel, that have been able to help out with that. And I'd love to take any questions. Yes. Yes.
But, the part that you had used for gene expression is that you use that to select, those proteins. So, but throughout your, I guess, research that you use, antibody-state protein. So I wonder that why why this whole project have emphasizing multiple gene expression rather than saying, this is multiple protein panel.
Just for terminology?
Yeah.
I apologize if I am using it incorrectly during there. Yeah, I think.
No, I don't think it's necessarily incorrectly, but I think it's probably people are more tend to accept the multiple gene expression type of approach rather than multiple protein type of approach. Is that
okay.
Right?
Yeah, I guess, yeah, that's a good point.
Okay. Well, another
Yeah.
question is, so have you validated the algorithms that you show where you can achieve, area under the curve of, let's say, 0.7? Have you applied to, say, an independent set of microarray data, and then to see that whether that is going to be?
Yeah, and actually some of the tissue microarrays, we had two different sets that we used, and one of them was kind of the training set that we used to validate the study prior to then trying to select which ones would be appropriate on the remaining stuff. So there was a training step and kind of validation step that I didn't describe in detail that we did on top of what I discussed today.
Okay. And then last question is, so have you done anything linked back to the MRI image?
There is work on that, and I don't have all of the details because that's still kind of a work in progress, as we still have prostates that I need to go annotate even yet today probably. But there is still MRI data, and Greg Metzger has been able to analyze and do a fair amount with that. And I try to skew a little bit more towards the work that I've done specifically. But yeah, they're starting to try to draw that back and do that correlation back to what imaging findings they're able to get from those very, very high resolution, the multiparametric MRIs.
Thank you.
Dr. Linden?
Based on your data that you observed during the TMAS, we can delineate aggressive versus indolent
That would be an interesting point. I don't know that we have, the initial prostate biopsies on those patients, but that would be an interesting point to be able to see, yeah, exactly, if we're able to elucidate from that initial assessment who needs to go further, who doesn't. That's very good.
Actually, a question related to this. You are building a predictive model. If you include a Gleason score there,
Mm-hmm.
to show your marker has an independent value on top of the current standard practice, that would be better to validate the value of your work.
Sure. Showing that, yeah, okay. And a fair amount of that, is, I think, been thought of. I don't know if we're actually doing that yet now, but, as far as having access to the actual prostate biopsies for our tissue microarray, we don't, and I don't know if they do on the larger cohort from the ovarian cancer, prostate cancer screening group.
I think this is kind of the most common practice for this type of work, is you demonstrate your result correlate with the outcome.
Mm-hmm.
Then you add another marker to it, that all of a sudden the significance all changes. So you got to analyze it in a multivariate fashion, so to demonstrate the independent significance.
Very good. Any other questions, Dr. Eiffel?
I had a question about this NCI 1,000 samples you have validate. I mean, do they have tissue slices from whole prostates? I mean, how?
The information I have, my understanding is that it's tissue microarrays, and they have detailed follow-up on all these patients for a number of years, depending on, clearly they have a larger repertoire than we have access to. And, I don't even know that, the greater than 1,000, I don't know how many it is.
But you don't know if it's not tissue blocks of all these things?
Well, it may have been what they had initially, but I know that the interest we have in it would be utilizing the tissue microarrays, and so I know they have that accessible, and I don't know what's remaining of
But
them.
what you mean by microarrays, they have this digitized images of them?
No, I think they've actually cored out portions of each of the prostate cancer blocks and then aligned them into a grid and it re-embedded those kind of cylinders of a number of different prostate cancers on each blocks, and so they've got a large number available for analyzing.
The other place where you might find, depending on that, is there's the CALGB or the Alliance group has that kind of information available now, and in fact there's been a big movement to have to share those tissue things with research, and they all have the same kind of outcome data and
the appropriate follow-up and stuff.
Yeah, because there are parts of people who've gotten treated in clinical trials who have had microarray.
Larry True has got 7 or 8 of his TMAs, so I'm certain that Steve probably has some resources now.
I think that'd be really interesting to see whether you can come up with. It's always interesting that a lot of times when you run the same thing on a different set of tissue, you're going to find 3 different genes.
Yeah, exactly. No, exactly. And that's why we want to kind of.
Because other institutions, do the same study and they get they come up. This happened with lung cancer on multiple occasions. People would predict have these predictive things, and when they and 2 groups would have completely different gene signatures.
No, and that's why, a couple of the ones that we took a look at were ones that occurred multiple times, but you take a look at what's out there in the research and the list of the different genes that people say are significant or associated with aggressiveness, and
they're like this.
One-shot wonders, and almost mutually exclusive for a good number of them, and so trying to nail down what actually is the appropriate signature is a challenging and definitely not final thing at this point in time, so. Yeah, Dr.
I have a question about the MR stuff. What's the point of, what are they trying to do? They're trying to recognize different grades by the MR signature?
Yeah, I think, when we get into kind of the multiparametric, and again, I don't claim to be a radiologist as far as what they're actually able to pick up, but I think the goal is to be able to possibly identify some of these features earlier on. They can do stuff like the image that I showed where you actually can show extracapsular extension and some of those types of things even now. Some of the good radiologists that can interpret that and pick up on those things. And obviously, when we have the coil right next door within the rectum, you're able to get some very good images of the prostate gland itself. And as far as what it's actually able to pick up, I don't know what the different parameters are of this multiparametric MRI that they're able to delineate, if there are different signatures that they're going to be able to actually show just from imaging and correlate. That would be fascinating, but I don't know the physics behind that.
Are they doing spectroscopy, or are they just doing?
There was initially some work in spectroscopy, and I don't have that or have a full grasp on what they're doing with that, but there is, yes. That would be one of the roots of one of the goals. Questions? Very good. Thank you.